Thank you, Mr. Chairman. My thanks to the organizing committee for having me. So I'm going to present to you the case of a 70-year-old gentleman who has history of ischemic cardiomyopathy with a very low ejection fraction and severe aortic stenosis. This man was highly symptomatic with shortness of breath with minimal exertion. He also had lots of palpitations, dizziness, and lots of rounds of VT. The echocardiogram showed a very low EF of around 25% with AV max of 3 meters per second, which increased to almost 5 meters with dobutamine without any change in the aortic valve area. So the history is significant for coronary artery disease. He had CABG many years ago. His coronary anatomy is rather stable over the years with patent lima to LAD and a patent graft to the circumflex. His RCA is occluded, but he receives collaterals, and as I said, there is no change over the years. He had a Euroscore 2 of around 15%, so the decision was made to proceed with TAVI. He's relatively obese. He has a big annulus, not so much calcification, so the decision was to proceed with a Medtronic Evolut 34 millimeter valve. We didn't have any problems advancing the valve. The problem is that this man would go into VT very easily, even with pacing at 100 beats per minute. So we went ahead without predilatation. He developed during deployment of the valve VT and VF a couple of times, and we had to shock him. We're fortunate that he came out of it easily. So the valve was successfully deployed. We did have some paravalvular leak. We decided to go ahead with the dilatation with a balloon. We placed the balloon on the ventricular side because, as I said, we didn't want to pace very fast. And we're able to achieve a pretty good result in terms of the regurgitation. We still had some, but we were okay to accept that given the circumstances. So we're happy that we have a good result in this guy with a very poor EF and lots of ventricular tachycardia. But once we pulled everything out and we tightened the proglides, we saw some bleeding from the access site, and actually, when we took a picture after crossing from the contralateral side, we had a gush of blood coming out, as you can see here. So we know that would be a difficult bleeding to control. That's not just leakage, it's almost like the entry point is wide open. So as is the protocol in these cases, we advanced the balloon and we occluded the vessel, applying some manual pressure. And in the meantime, we're thinking how to proceed. There are a couple of things that you have in mind in this case. You're considering extended manual compression. You're thinking about a stent grafting with a usually covered stent or an open surgical repair. So after applying the pressure for around 25 minutes, we took a picture, and it looks pretty good at this point. So the option of the surgical repair goes away at this point. And we had a question in our minds, should we stent or not stent? And this may sound like a trivial dilemma, but it's not that trivial. If you're going to stent, usually you're going to use a covered stent, and below the inguinal ligament, usually we use self-expandable stents, although balloon expandable stents have been used. Why stent? Because that's a fast solution to your problem. The patency of these stents is pretty good, and they have a high rate of success, almost 100% in terms of controlling the bleeding. But you have a couple of reasons to avoid the stent. There is a restenosis rate, which is about 3 to 5% in the first year. Some of these stents may fracture. As I said, this is a hinging joint in the hip. And especially in younger patients, you want to keep the femoral artery easily accessible for future procedures, especially if other access sites are calcific or stenotic. So we discussed a little bit with vascular surgery, and we decided to give it another go at inflating again the balloon for another 30 minutes, since we had a good result so far, and applied a little bit of pressure. And we took another picture, which looked pretty clean. So we are convinced that we are okay. And we stopped there with careful monitoring of the patient. The patient did okay. He was discharged home the 4th day. The ultrasound of the area was normal. And a few months down the line, he's doing okay. The leg is good. He does not have any more runs of VT on ICD interrogation, which is a good sign, which seems that this aortic stenosis apparently was putting some extra burden on his LV in terms of arrhythmia. So in summary, large leaks like that usually are treated with stents, but in younger patients that might have a reasonable life expectancy, and you might need access to the femoral vein to be easy, and you don't want to have the problems of stent restenosis or issues like that, you might want to give an effort to manual compression, and oftentimes it works. Thank you.
Thank you very much, Dr. Georgakopoulos, reminding us that TAVI procedures are 2 procedures in one. One is putting the valve, and the other one is taking the system out. So, any questions from the panel or the floor? I think we should get moving. And last but not least, from